So I'll start with my talk on KILD, which this terminology has become very popular now. And as we know, the developmental anomaly of anterior segment can be divided as iridotrabecular dysgenesis, as we see in primary congenital glaucoma, Axenfeld-Rieger syndrome, and iridia, or it can be keratoiridolenticular dysgenesis. So this is the terminology which has been given, and it is basically because of the defect in the neural crest migration in the 6th and 8th week of gestation. So as we know that the neural crests derived cells migrate from periphery towards the center to form the iris stroma, corneal stroma, and corneal endothelium, and this migrations separates the lens vesicle from the corneal epithelium, because both of them originate from the surface ectoderm. So in KILD, the cell migration process is defective with resultant posterior corneal defects and opacities with or without iridocorneal or keratolenticular adhesions and cataract. So basically, there are several classifications, and this classification is quite useful. Dr. Ken Nischel has classified congenital corneal opacities as primary congenital corneal opacities and secondary congenital corneal opacity, because these conditions are associated with corneal opacities. So they fall into the category of secondary congenital corneal opacities. So KILD can also be categorized according to the type of dysgenesis. So it can be just iridocorneal adhesions, which is traditionally called Peters anomaly type 1. Second one is corneo-iridolenticular adhesions, that is called the Peters anomaly type 2. So in type 2, we have lenticular adhesions as well, because the lens failed to separate. And then there are other categories. The lens separates, but then it becomes reapposed, or lens separates but fails to continue to form, or the lens fails to form at all, the congenital aphakia. So this is again a very severe kind of dysgenesis, and the prognosis is very poor in congenital aphakia cases. So now coming to Peters anomaly, it is rare, and the phenotype can range from mild corneal peripheral opacity to severe opacification involving the central 3 millimeter. So basically it is associated with a typical defect in the Descemet's membrane and endothelium with adjacent either iridocorneal or corneolenticular adhesions. Cataract may or may not be there. So basically why these arrest happens is, in type 1, DM defect may represent primary failure of corneal endothelium. In type 2, there is incomplete separation of lens vesicles from the surface ectoderm, or lens, as I said, lens can develop normally, but then it is pushed forward against cornea, causing loss of DM. There is other classification also where they have been divided into three groups: cornea with central leucoma only, cornea with central leucoma and corneal lenticular touch, and third is cornea with central leucoma associated with Rieger mesodermal dysgenesis. So you can have iridocorneal adhesions at the periphery also. So these are various classifications, and you can follow any of them. So just a little bit about Peters anomaly type 1. So it may or may not be associated with glaucoma, because only 50% of the patients have glaucoma. So the opacity may be central eccentric or less commonly total, and it is invariably avascular. So the differentiating point is that there is no vascularization here, as opposed to Peters type 2 where there is vascularization. I am going to show the pictures. There are iridocorneal adhesions. Again, there will be no corneolenticular adhesions. And the mutations seen are PTEX2, FOXY1, CYP1B1, and PAC6. The prognosis is better because the lens is separate, and the results are PKP are good. So UBM offers valuable information about these situations, these conditions. Type 2, there is usually vascularized central or corneal, total corneal. As you can see, the vascularization is coming up to the center. So in UBM, you will see the cataractous lens with the anterior lens capsule not discernible at the point of attachment, and the mutation is FOXE3 here. So the prognosis is not so good. These are some of the pictures. As you can see, there is lenticular corneal adhesion here, complete loss of Descemet's membrane, and the lens is attached to the cornea, which is beautifully seen in UBM pictures here. Third condition is lens separates, but then again becomes reopposed. So, what is the pathology is that there could be hypoxia or persistent fetal vasculature pushing the lens forward onto the cornea, or it can be associated with aniridia with very shallow anterior chamber and keratolenticular touch. So here the surgical removal of lens, when the lens is attached to the cornea, you have to remove the lens, do the cataract surgery, and allowing the recovery of endothelium on its own rather than primary corneal transplantation. So first you do remove the lens and just let the cornea recover on its own without peeling off the anterior capsule which is adherent to the cornea. The fourth situation is where the lens separates but then fails to continue to form. Again, there is corneal opacity, and you see in UBM there's hardly any space between the cornea and the lens. Again, here since there's a complete fusion here, concomitant PKP with vitrectomy is needed. However, the success rate is low. Other condition which we get to see, although it is not very common, is where the lens failed to form at all. So here you can see the silvery hue appearance of the cornea, which allows transillumination, and the eye may be micro-ophthalmic because, as we know, and Sushmita also said in her presentation, that lens is instrumental in developing and promoting normal corneal growth and the anterior segment structure. So if the lens is not developed, the entire anterior segment structures go haywire. And the mutation is FOXE3 again, and again it is diagnosed with UBM. And one should be very careful in touching these eyes surgically because they can go into phthisis because of the formation of thick cyclitic membrane. So it is always better to manage them conservatively or with very little intervention. Peters plus syndrome is associated with systemic anomalies like cleft lip, cleft palate, developmental delay, short limbs, broad extremities, etc., along with Peters anomaly. So these are the conditions which have a lot of overlap, but we do see them and diagnose them with the help of ASOCT and UBM. Genetics, they are associated with the abnormalities or mutations in the genes like FOXY1, PITEX2, and PAX6. So these are called homeobox genes, and these are the parent genes which are responsible for formation of the anterior segment structures. So if something is abnormal in these genes, then the entire anterior segment gets dysgenetic. So glaucoma doesn't happen in all the patients in Peters anomaly. It is 50 to 70% may appear later, and elevated IOP could be because of trabecular dysgenesis if it presents at birth or during early childhood, or later on because of the closure of the angle because of iridocorneal or corneolenticular adhesions. So there's one series wherein 34 out of 58 eyes developed glaucoma, 2.8 years, plus minus 6.4. And glaucoma is more common as expected in type 2 because there's a lot of dysgenesis there. And some of these eyes, out of 34, 20 eyes required glaucoma surgery, and the child may require multiple glaucoma surgeries. And here they suggested that the glaucoma drainage devices had the best success rate, 53%, and cyclophotocoagulation had 67% chances of success. Trab with mitomycin C was not very successful, and 15 eyes they underwent glaucoma surgery uh, with GDT and cycloablation accounted. So these children have to undergo multiple surgeries. So just a few cases. So this was a 6-year-old boy. He had corneolenticular adhesion in the periphery with peripheral corneal opacification, and the pressure was slightly high. So this was a mild case of Peters type 1, which was just managed as of now with the conservative treatment. It has to be differentiated because this eye, this particular child has a complete corneal opacity with a ophthalmos. So it's very important to do a UBM to see if there is any anterior segment dysgenesis, if there is any adhesions, the iridocorneal or lenticulocorneal. If there are no adhesions, as you can see here, the lens capsule is intact. There is absence of iridocorneal adhesions. So this is a simple case of PCG, which responds pretty well to trap plus trap. This very interesting case which we encountered, which came to us 3 to 4 months back. He was a full-term normal delivery. Birth weight was good. There was no, delayed crying, or the pregnancy was uneventful. The pressures were high when he presented to us 10 days after birth. And this was the situation. You can see the clearing of cornea in the center rest. The entire cornea was opaque, and the corneal diameter was more in the right eye. In the left eye, it was okay. The axial length was also high in the right eye. The pressure was also high. So this Peters anomaly was associated with congenital glaucoma. So this is the UBM picture. At one point, I could see this lenticulocorneal adhesion, and therefore I thought it's Peter type 2. And in the other eye, although the AC was very shallow, but there was no adhesions of the lens, and the normal lens echoes were seen in the UBM. The pedigree analysis showed that there was no one in the family who got affected. So type 2 Peters anomaly in right eye and type 1 in the left eye. And I just took up the child for trabeculectomy, thinking that I won't be able to do the trabeculotomy, but somehow I could pass a trabeculotome in the through the Schlemm's canal. You can see the fluid coming out from here, although it was very difficult. So, but this child right now, in terms of IOP control, is doing well in both eyes, strap plus strap was done. Although he has corneal opacity and some delay in the development, which needs to be tackled with. Another case where there was complete absence of the lens. So again, in most of our patients, consanguinity is present, because we get patients, mostly Muslim patients, who have consanguineous marriages. And the mother was positive for rubella and HSV, and the child was also positive rubella and CMV. So in one eye he had microcornea with sclerocornea, and in the left eye he had bleophthalmos, as you can see, with silver hue appearance. And this is the UBM picture. UBM is very, very important. Again, I'm emphasizing, and there is no lens echoes which are seen. And in this B scan also, there were no lens echoes seen or PC noted. And one eye was micro-ophthalmic, 11.62. The other eye had the axial length of 14.25. So the diagnosis of both eyes congenital aphakia was made. So we have just put the child on conservative management right now, because the prognosis of doing surgery in such eyes is really, really bad. And these are the reports. So the key investigations for anterior segment dysgenesis is, I would say, along with the glaucoma assessment with tonometry, gonioscopy, the ultrasound biomicroscopy or ASOCT, and B-scan ultrasound to measure the axial length, because some of them may be associated with microphthalmia. And for each of them, the assessment with pediatrician is very, very important. Role of UBM, you can see the absent Descemet's membrane, defect in the endothelium, here bridging Descemet's membrane, and here you can see the iridocorneal attachments here. And here you can see the iridolenticular attachment in this patient. You can see here, and you can see here the central cornea which is attached to the lens. So I think all these clinical features can be very well delineated with UBM. So I would say you should have UBM if you are practicing you're practicing pediatric glaucoma. And the molecular diagnosis again is important, although it doesn't decide about the treatment. The management will remain the same, but it's important that you know about the genes, which is useful. I'm going to ask Sushmita in which cases you order genetic testing. And also, taking a good family history and pedigree helps direct the correct suspected molecular diagnosis. So pedigree testing is very, very important, where you will know whether it is the autosomal dominant or autosomal recessive inheritance, and you can even screen the parents. Sometimes the parents do not report, because autosomal dominance has variable expressibility, So the parents may not know about the disease. So if you do the pedigree charting, and if you find the inheritance pattern, then you can even screen the parents. And sometimes we have found that the parents have some amount of, dysgenesis in a child who presents with congenital glaucoma. So the management, again, with medical management or surgical optical iridectomy, especially in Peters anomaly where there is central corneal opacity, you can just do an inferior iridectomy. You may not do a PK, and then the treatment for glaucoma, whether medical or surgical, depending on the status, and symptomatic management of various systemic manifestations. It's a multidisciplinary approach, and a referral to the pediatrician is very important, and to a pediatrician or a counselor who is familiar with the developmental surveillance and intervention in young children with visual impairment to optimize development. So this is the chart in one of the papers where how to manage Peter type 1 and 2 when they present with the corneal opacity. In mild disease, you just can observe. In moderate disease, you can do optical iridectomy. In severe disease, you have to do PKP, and if the lens is attached, you have to do the lens extraction, and plus minus vitrectomy, and finally PKP. So you have to weigh the risk versus the benefit, and you have to talk to the parents about the prognosis and the need for multiple surgeries for these children. Some of them have poor prognosis.